The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We've been talking about all sorts of things related to voiding this month with Dr. Glen Lau. Welcome back. Thanks for spending some time with us this month.
Oh, thanks for having me. Glad to be here.
So we talked 2 weeks ago about nocturnal enuresis, last week about dysfunctional voiding. I want to talk about a topic that's sort of closely related. We spent some time with Rajiv Iyer last month talking about spina bifida and tethered cord and that sort of thing. And it seemed like it would lend itself to talk about neurogenic bladder this month, if that's okay with you.
I'd be glad to do it.
Great. You developed any financial disclosures?
I have not.
All right. Okay. So what is neurogenic bladder?
So neurogenic bladder would be where there is abnormal sensation and neuromuscular control of the bladder. That can be secondary to a number of different issues. Most commonly, the ones that we would see would be a congenital neural tube defect, so spina bifida or myelomeningocele, and then also things like spinal cord injury, transverse myelitis, like an inflammatory condition, something like that.
And you mentioned a couple of weeks ago, but if you wouldn't mind mentioning again, how are things different neurologically in a neurogenic bladder?
So neurogenic bladder can be, there are a few different divisions of neurogenic bladder, and it depends on kind of the level of the defect. So you can have basically a flaccid neurogenic bladder where you have actually interruption of the pelvic plexus. So these are the nerves kind of going directly to the bladder after the spinal cord. And that has kind of a typical picture to it. Whereas, a higher C-spine lesion or a, spina bifida, those types of things, that would be more of an upper motor neuron issue. And in those cases, it's a little bit of a different picture and maybe even a little more unpredictable.
Given that they're different type of neurogenic bladder, what are the common symptoms that we should be concerned about?
Well, in evaluating these patients, and they can be very complex from a urologic standpoint, we kind of have, I guess, a tiered system of priorities with them. So, the first thing that we're worried about, and the first priority for any urologist, is kidney function. And these children can have basically a hostile bladder that can put back pressure and reflux towards kidneys and can cause chronic kidney disease and in extreme cases, end-stage renal disease. And so that's something that we have to be sure to evaluate. The second is that we want these kids to avoid urinary tract infections, which we know can damage kidneys, first of all, but second of all, can, cause other even life-threatening issues. And then lastly, we want them to, at an appropriate age and circumstance, be able to be dry if possible. And so social continence is another thing that we kind of worry about with these kids, and probably is the most obvious symptom of neurogenic bladder in a kid who should be otherwise potty trained.
Are there kids who arrive with just neurogenic bladder and there's no suspicion that there's anything else been going on, or is it more common that this is a child who has other issues and has neurogenic bladder in addition to that?
Yeah, I would say this is something that we probably pick up mostly because they had a spinal cord injury or were born with spina bifida and had their defect closed and those types of things. Every once in a while, we will run into a patient who has a tethered cord, or there is some spina bifida occulta or something going on that, they manifest from a urologic standpoint first. And so we do have to have our suspicions, but I would say the large majority of these are caught after an injury or at birth.
But after talking with Dr. Iyer about tethered cord, it is something that, of course, is going to haunt my consciousness about.
Right. Yeah. And we always have to rule it out. And, if we have refractory daytime incontinence, for instance, we will get an MRI of the lower spine just to make sure, the lumbar spine, to make sure that there's not an issue like that going on.
Sure,
Yeah.
sure. And you've talked some about the impact, but it is something that has great impact on both a patient's life and on their family's life as well.
Yeah, for sure. And I think that's important with these children. First of all, there's a variety, if you've ever visited our spina bifida clinic, there's kind of a spectrum of developmental abilities and things. And you also have to be kind of aware of what the child's capacity and what their goals are, and what the parents are expecting. But yeah, it can definitely, lead to some psychological impact in some of these kids who are higher functioning. And
Sure.
it's something that definitely can be a challenge to manage. If you think of what it takes to do clean intermittent catheterization compared to a person who just is able to normally go and void on the toilet, that's a logistical and time issue for those patients for sure.
Let's talk about some of the things that you can do to treat neurogenic bladder. Are there lifestyle changes that are simple enough to help with the management?
So there are children that we see who have an element of neurogenic bladder. They have some sort of a lower spinal cord lesion or something like that. And they are able to do a decent job of emptying their bladder, but they may have just kind of overactive bladder symptoms. And so those patients, if we've established that they're able to empty, that they're not having infections, that their upper tracts look normal on ultrasound, then we can use kind of our algorithm for voiding dysfunction to treat those patients and kind of start with timed voiding, add medications and those types of things. So that's definitely an option for some.
Tell me about the medications. I mean, it's similar to what we talked about last week.
Yeah, medications are basically the same. The goal with the medications can be a little bit different though. So in patients who are of an age where they can only take liquids and we have to start with something FDA approved, it's going to be oxybutynin first. There are then obviously other anticholinergic medications like we alluded to before. And then the one difference with the other class of medications is that Myrbetriq or mirabegron is actually FDA approved for kids with neurogenic detrusor overactivity or incontinence between 3 and 18. So we do have that option that's actually should be covered by insurance.
So reference somewhere to Botox. What can you tell me about that?
So Botox is technically a surgical option. So it's something that I realize it's a medication, but it has to be delivered by a cystoscope. So we actually, in kids, would not do that in the office, although there are adult facilities that will do this in the office with a patient.
Oh, interesting.
But with Botox, yeah, it's cystoscopy. And then we use a small needle and inject a solution of botulinum toxin and saline kind of throughout the posterior and lateral walls of the bladder. That's something that I would call then our third line, right? Because we would use that in patients who are kind of refractory to medications.
Did I interrupt you before did you have other medications you were going to talk about?
No, I think those are kind of the main ones. We didn't get into with the voiding dysfunction talking about Flomax for kids who have poor emptying. I think that probably has more application in that population than in the neurogenic population. But in kids who have kind of troubles, relaxing and they've got a very tight bladder neck, you can actually off-label give tamsulosin or Flomax, and that can sometimes help with emptying. So I guess in those kids who are able to void and are not catheterization dependent, that could be an option in this population too.
Oh, interesting. Tell me about clean intermittent catheterization in this population.
Yeah, so that's usually the mainstay for most of our patients in this category. And this is for kids who want to be dry or who need to empty periodically because their leak point pressure, or the pressure at which they empty their bladder, is high. And so I would say the large majority of our patients, for instance, in the spina bifida clinic will require intermittent catheterization at some point. And most of them, it's kind of when they have a desire to be dry, but sometimes we use it just to kind of keep the upper tract safe, to keep the pressures periodically lowered and keep pressure off of the upper tracts. The other thing that it can help with is in patients who are having infections. One would think that maybe introducing a catheter into the urinary tract might increase your risk of infection. But in kids who have very poor emptying and urinary stasis, then periodically emptying the bladder allows kind of the flow of urine, decrease stasis, and can reduce the risk of urinary tract infections.
What period are you talking about? How often do you end up doing that?
So I would say our kind of first interval would be every 4 hours. That's kind of the standard where you start. And then if continence is the goal, then you kind of can ramp that up to every 3 hours. And usually if we're going every 2, that tends to be a little bit much for patients. So then you start looking at other ways of trying to increase capacity and things like that.
And how do you do that?
So medications can do that. You can get some increase in capacity from like an anticholinergic or a beta-3 agonist. The third and fourth line would be Botox as a surgical option, or in more extreme cases, bladder augmentation, where we actually surgically basically patch on bowel to enlarge the bladder.
Okay. I saw something about electrical stimulation. Is that a thing?
Yeah, so that's something that probably belongs more in the overactive bladder or lower urinary tract dysfunction realm. There are stimulators, but when kids have kind of an issue with the neurogenic bladder, then stimulating those nerves that then innervate the bladder doesn't tend to work quite as well. So it's probably of limited use in this specific population. Yeah.
Okay. Other things we ought to know about neurogenic bladder?
Well, I think these kids, they can be really complex to manage, and having kind of a systematic way of looking at them, I think, is really important. In urology, we deal with constipation on the neuro intact side, but we also tend to manage bowels for these patients. And so just like constipation can impact bladder function in a neurologically intact child, same thing can be the case for a patient with neurogenic bladder. And so it's important to kind of keep tabs on how they're doing and what they're doing to manage their bowels. A lot of these kids will be on some sort of stool softener, and eventually, since they don't really have control of things, for social continence, they'll end up on an enema program. And making sure that that's functional, that they have the ability to do that, is very important. And I would say it's a lot more evident when they're in a social situation if they're having bowel accidents than if they're having urinary accidents. And so that's a big dissatisfier if we don't have that under control.
Absolutely.
The other thing is kind of thinking about our kind of hierarchy of needs with these patients, and making sure that their upper tracts are looking okay, that they don't have any new hydronephrosis on recent ultrasounds. We do get lab work on these children periodically to make sure that they don't have any kind of occult chronic kidney disease creeping in. Asking them about urinary tract infections to make sure that we don't need to change our management somehow to prevent those. And this is a population that we will do urodynamic studies on pretty regularly, actually. So, if we're trying to make a change in management and trying to get them dry, you need a lot more information with these kids, because if you're potentially talking about surgical options or you're trying to make medication decisions, then that urodynamics testing can really be essential. And also, if they're used to cathing, then the urodynamics test really doesn't matter to them quite as much.
Sure. And it does seem that in the context of neurologic disease, neurologic injury, neurologic dysfunction, this is a very important element, because everywhere from the social implications to the life-threatening implications of protecting kidneys.
Correct. Yeah. And so I think that we obviously maybe take a little backseat to the neurosurgeons in managing these guys in the spina bifida clinic. But it's interesting to see how many come in with the plan to see ortho and neurosurgery, and then they say, "Oh, by the way, we need to see urology too, because we've got this issue going on."
Yeah. All right. Anything else we ought to know about neurogenic bladder? Well, there's a lot, but
there's a lot. This could be a couple of month podcast if we wanted it to be. But I think that this is one where if you have a patient who has a neurogenic bladder, any changes that are noticed by the parents or the patient could represent something underlying that really needs to be worked up. And I think it's always reasonable to touch base with us. If there is new incontinence, we've had a patient that we've kind of gotten dry and then they're getting worse all of a sudden. if we've got infections that have been kind of recurrent, or if we see a change in renal function, those are things that are really important for us to know. They're only seeing us maybe once a year if we're kind of doing our autopilot thing. And, if they're having issues in between, then that's something we would want to know about sooner rather than later. And the other thing about these patients is that they are, especially in childhood, very dynamic, right? The urodynamics one year could be completely different than the year before. And so as they grow, something that looked like a safe situation could turn into one that's not. And so, we try to take a very proactive approach in taking care of these patients. But yeah, yet another reason to give us a call if there's a concern.
One of the great advantages of having these patients in a multidisciplinary clinic is that there's easy consultation going all directions. And I think one of the things that strikes me over the course of a career in general pediatrics is that that's really the key to taking care of all my patients, is a consultation with people like you makes my patients' lives better. So thank you very much.
Oh, thank you.
All right, sir. Well, we'll look forward to talking to you again next week and talk about whatever questions that have come up. We really appreciate your time and expertise being with us this month. Anything else you want to say about any of these topics?
No, I think that, if there are any questions, I'm more than happy to answer those. I'm also more than happy to take any curbside consults, if you will, over the phone anytime. So thanks for having me.
We will touch on that again next week. For those of you who have questions, please send your questions to questions@vcurb.com. Thanks to Elisa Stoddard for all her hard work in making this sound like a podcast and making all the elements come together. And thanks, Janice, for listening. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.